We just minimize the people up the other, right?
About the scene for these slides, is it iron up? Was it down under the slab? So we just now. Sorry for those online, can you see our slides and hear us properly? And we're going to assume just.
Yes, we can.
Thank you.
Yes.
Right there.
Yes.
Yes.
Thank you very much. I'm Rosemary. Just a disclaimer, I'm a pathologist. So today I'm presenting a case that we saw in September. This was the primary presentation. It's a 24-year-old female who hails from a Litwa. Okay, she presents in pregnancy. She's unemployed, and this is her first pregnancy at 27 weeks. And she has a so-called normal booking plans. She's HIV negative and RP. So she presents with a 1-week duration of the following symptoms. She has sore throat, generalized itchy rash, which started out as verticarial rash on presentation, and then she later became a fine sort of orbital rash. She also presented reported palpitations, nausea and vomiting, abdominal pain, and decreased fetal movements. The documented examination on arrival was that she was tachypneic, wasn't the exact respiratory rate wasn't documented. She had a maternal tachycardia of 150 beats per minute. That was an ECG pattern used by Q3T3, suggesting right ventricular strain. She had a blood pressure that's documented there, 165. That was her heart rate during that monitoring period in the ED. And she was apyrexia. Her abdomen, she had right upper quadrant tenderness. These are investigations, largely normal, really no true concern with regards to what's mentioned on the screen. Her SR was normal, all of her LFTs were quite normal, her creatinine was normal, white blood cells, eosinophils, and her HB were all fine. So in the emergency setting, what would be your sort of top differentials? I mean, at this stage, what would you consider?
Health syndrome, it's kind of concerned with the right quadrant pain, the doctor's pregnant. So that would be a top concern.
So I just put 2 pulmonary embolism and later on the considered viral myocarditis. Of course, these are high consequence conditions that we considered in the setting. So the primary concern in the emergency unit was acute pulmonary embolism, and those were the supporting features, sudden shortness of breath, high risk state of pregnancy with tachycardia, and that ECG pattern, which just to note is quite non-specific, especially in pregnancy. So they, of course, requested a CT angiogram, pulmonary system, and this was the results that were obtained from that CT. There were no central lobar pulmonary emboli demonstrated on the study, and there were no features of right ventricular strain. And then they noted an incidental cystic liver lesion in those anatomical segments 8 and 5. So any expanded differential or important questions that you'd want to know at this point?
Symptoms were
Normal.
at which point did she pop
Very travel anywhere or so she does have exposure to animals, yes. She has from the Eastern Cape. She doesn't currently have a dog, no, but she has previous exposure to animals, yes. So there's a lot of informal farming where she's from, between the Eastern Cape, so she has exposure to sheep. So Oh, so nice.
And she had a reason on cost, like her bilirubin and her all of that. That was.
So I think it's important to find out some more about the cyst. You want to know the nature of the cyst. So it had a floating membrane. It was about 7 centimeters. So just an expanded differential. I've just highlighted the infectious causes and differential to consider during discovery of a hepatic cyst. So of course, Hydatid needs to be considered. A big abscess and pyogenic abscess should also be considered, even though it's cystic on imaging. But because she had a normal CRP, normal eosinophils, and this floating membrane, it was indicating membrane detachment, which I'll describe later, pointing towards Hydatid. So these are our serology results, which is something that you'd want to acquire, seeing that as an incidental finding. So her IgG was positive and her ELISA was also positive, indicating Hydatid disease in pregnancy. And the diagnostically, you utilize imaging, serology, and also most importantly, a history of residence in an endemic area. Hydatid is one of the endemic areas in our country. So I'm just going to go through some dilemma discussions during this case that came up and that I found quite interesting during our discussion. So firstly, imaging dilemmas. It's a pregnant patient. So CT is often limited due to the radiation risk, and it's generally avoided in pregnancy. And then the question comes up, MRI versus ultrasound for staging. And the MRI does become important. I think its sensitivity is quite similar to CT, but it becomes more important when you're planning surgical intervention, and also when the cyst is located in the posterior segments, and also if there's biliary communication. You want to see the type of communication that's happening, and then also important cystic rupture. So in pregnancy, ultrasound is the primary modality and is sufficient to classify most hepatic hydatid cysts. This case, CTPA was done and it was an incidental finding, but of course the risk-benefit ratio was ironed out by the attending clinician. Then discussing albendazole use in pregnancy, it's contraindicated in the first trimester because of the teratogenic risk in pathogenesis. It's got conditional use in the second and third trimesters for complicated cases only. And the decision, as most of the decisions in this case, is really a case-to-case basis with a multidisciplinary team approach. And yeah, you're going to look at the benefits versus risk consideration. So the dilemma here is, should albendazole be deferred postpartum, or is disease too high risk to delay? And most multidisciplinary teams prefer postpartum albendazole unless maternal complications occur. And those complications are associated with rupture and anaphylaxis. And then you outweigh that fetal drug risk. Looking at interventional dilemmas, so whether puncture, aspiration, injection, and re-aspiration or surgery is to be considered. So PA is usually safe, but there is a risk of spillage and anaphylaxis, and there's obviously limited evidence in pregnancy. And then surgery, if there are really large multiple cysts, ruptured cysts, or recurrent disease with the complications associated, such as compression of the biliary structures, risk of preterm labor, life-threatening mass effects, super infection, surgery does become important to consider. So the question in this case was, do we intervene in pregnancy or wait until postpartum? And like outlined, above is the risk of spillage and anaphylaxis preterm labor really needs to be considered. There's most authors suggesting that it should be avoided unless it's really likely. And then just looking again at intervention, but trying to look at how pregnancy plays a role in the risk of cystic rupture and life-threatening anaphylaxis. So with the increased intra-abdominal pressure, especially in the third trimester, you have an increased risk, post-trauma during the birthing process, uterine enlargement, increased cystic growth due to immune modulation. You have reduced maternal cell-mediated units, so the heightened progesterone and estrogen. I think also 4% of steroids, which can all lead to rapid cystic growth and risk of rupture. Also diaphragmatic displacement. Then the rupture consequences are quite broad, with anaphylaxis really being of concern, but also peritonitis, internal shock, of course, secondary hydatosis, and fetal hypoxia, preterm labor, those are all to be considered. Then, of course, like with all pregnancies, one needs to look at the timing and the mode of delivery. So this was also, under consideration during this case. So vaginal delivery is usually possible, and it's really caution must really be practiced if you have a very large cyst that's pressing on the uterus. And cesarean section, it's just important to know that that can risk cystic rupture, and you sort of need to consider whether it's really indicated. Then also very interesting is neonatal considerations. So congenital transmission is really very rare just because of the pathogenesis, and it requires an oncosphere from the maternal circulation. Well, firstly, it requires it to be in the maternal circulation. They often, they should be sequestered in these well-organized cysts. So they shouldn't really, unless there's massive antigenic shift due to rupture. So with regards to the pathogenesis, the oncosphere actually has to leave the cyst. So during rupture, we need a huge antigenic load, and then it needs to cross the placenta. And that's really very rare. And I've only found one case. So the question was then, should a neonate be screened postpartum, and which infants really need follow-up with either imaging and rarely serology. And it should really be risk-based, and it's not routinely done because of how rare this is. This is just a completed slide of the interaction between pregnancy and Hydatid disease, and just outlining the complication risks, which are quite broad and affecting many of our participants. So the key clinical question during this case was, what is the safest management approach for transitional Hydatid cyst? The term transitional is based on the World Health Organization staging system. It's an expert group that have come up with a staging system based on the imaging appearance, the ultrasound appearance of the cyst in late second trimester of pregnancy. And I think the answer is conservative, non-interventional management during pregnancy, and then with postpartum definitive management. So the initial decisions, which were made in this case, were basically that it's unlikely to rupture this specific cyst, and they opted for conservative management, but they did opt for albendazole. The patient was also placed on ketroaxone and metronidazole for the concern of bacterial co-infection. Subsequently, there was a multidisciplinary team involved, including infectious diseases, and surgical management was deferred, and that was supported by sound reasoning, anatomically challenging position, the sort of anterior right, which shifts during pregnancy to really lateral right, and any sort of aspiration would be dangerous because it's quite acute, the abdomen. And then there's a high risk of needle-induced rupture. There's no biliary communication. There's no evidence of superinfection. And there's a large uterus, of course, so there's safety and exposure issues. And then it's a transitional cyst, so it's not an ideal care candidate during pregnancy. So the benefit doesn't outweigh this. Subsequently, it was decided that secondary infection is quite unlikely. Lack of communication of the pulmonary system, antibiotics, the ketroaxone and the metronidazole was stopped. And the decision was also made to stop albendazole this September admission and discharge with close follow-up by ID hepatobiliary and a high-risk antenatal care clinic. So why was albendazole stopped? Just, I've already mentioned that in the second, third trimester, this is maternal benefit and it really outweighs the risk which was decided that doesn't. But besides that, you do have the risk of early cyst degeneration with increased rupture in large cysts. So this was quite a large cyst, later found in formal abdominal ultrasound. And there's also an inflammatory reaction that you risk within the cyst. And this cyst was stable. So stopping the albendazole is important to avoid iatrogenic cyst destabilization too. And it was the safest option. In October, the patient presented and complained of right upper quadrant again. And there was, of course, the concern for rupture. The patient was clinically stable though, and the examination of a lab investigation, so quite unchanged. The formal abdominal ultrasound was then requested. So I've just put the structure of the kind of cyst just to help us look at the findings. So it's usually spherical or semi-spherical, maybe compressed by organs, and it all depends on the pericyst or the integrity of the pericyst, which is a host-derived fibrous tissue. And the exocyst and the endocyst, which you can see is that white sort of laminal layer, as well as this germinal layer. So those are parasite alive. And the germinal layer produces these brood capsules, which is indicated to the side, and protosphoruses. And that's sort of the key therapeutic target, and it also drives cyst viability and recurrence. So that's sort of our targets for treating both surgically and medically. So these are the ultrasound images, and this is known as the water lily sign. And that is when these two layers, the laminal layer and the germinal layer, separate from that host-derived pericyst fibrous. And then you see this water lily sign, which was nicely observed on her ultrasound images. And I've just highlighted this is the World Health Organization classification, which aids in diagnostics and guides therapeutics prognostics. So she basically falls in the transitional sort of stable cyst. So this was then noted to be much larger than was noted on the CTPA. Attached membranes, no calcifications, and no border vesicles, and no edema or anything really alarm. No new solid organs were noted, and there was still no communication with the retrieval. So consistent with a large intact transitional hydatid cyst. No features of rupture were noted, and it was really an uneventful admission. She was seen by obstetrics for high-risk antenatal care clinic follow-up, and pathobiliary clinic follow-up also arranged. She was clinically well and discharged, and the plan was for her to go straight to maternity ward on a re-presentation, aiming for a normal vaginal delivery. And cesarean was to be considered only with obstetric indication. So just looking at echinococcus, it's a zoonosis caused by cestodes in the genus Echinococcus. It's one of the 20 neglected tropical diseases recognized by the World Health Organization. And it really does cause significant morbidity and even mortality in South Africa. There are 4 species of Echinococcus that cause infection in humans. Echinococcus granulosus, multilocularis, regardless. So polycystic echinococcus really occurs very infrequently, and I've put in this really beautiful table just to show the different species and the disease that they cause. Also, just to highlight that granulosis is the most common of the species, causing significant morbidity and mortality. So the definitive host where sexual reproduction and maturation occurs is dogs, and the intermediate hosts are sheep, goats, cattle, camels, and servants, and humans are aberrant, really incidental. So with regards to in South Africa, looking at it's endemic in rural Eastern Cape. KwaZulu-Natal and Western Cape, and it's linked to the dog-sheep cycle in those areas, as well as home slaughter, and it's often acquired in childhood and presents in adulthood. So it's really a very long incubation, quite variable. Management challenges are obviously met because of the late detection, large cysts and limited access to surgical intervention. And prevention is dog deworming, dog movement control, and avoiding close contact with dogs, offal control, and avoiding contaminated food and water, as well as WASH principles and rural education, which will introduce really difficult points in the disruption of the kind of cycle because of economic issues. So larval stages produce disease, and the disease characteristics really depend, like I showed in that table, on the infected species. The cysts develop in liver, lung, neural tissue, bone. The diagnosis is sign-based, so slow-growing tumor and the history of residence in an endemic area is important on history. And as I mentioned earlier, the diagnosis is a combination of imaging and serology, and the World Health Organization did develop that nice classification. And then we come in, the humble microbiologists, to diagnose some cases microscopically, seronegative cases, and when we receive some of that hydatid fluid, we are able to see components of the hydatid SAM fluid, and that was the aids in diagnosis. I've already outlined the management options. I just wanted to outline here the medical management and the other options. Albendazole is your first line, really the cornerstone of therapy. It's the most effective, and it's cysticidal. It acts on those lamina and germinal layers. And then also just wanted to highlight combination therapy, really difficult to treat cases where praziquantel is added as a good sclerocidal agent. Suppressive therapies also then gets considered in where it's really difficult to cure. So this is the table that I had referred to earlier with regards to the stage and the therapy that's recommended per ultrasound by the stage. So just in discussion, maybe most cases of hydatid disease in pregnancy could be asymptomatic and discovered accidentally during antenatal care, so not always alarming. And then hydatid disease in pregnancy may lead to various complications in both the mother and the fetus. And diagnosis of hepatic hydatid disease is pretty straightforward, but management is difficult and problematic. There's no consensus on management of hydatid disease in pregnancy, and each case should be individualized and multidisciplinary. And then this was just added for the microbiologists, especially these one or two infectious specialists. So it shouldn't be notifiable. And I think it should be a notifiable disease, especially in endemic and rural livestock farming regions like the Eastern Cape and KwaZulu-Natal and Western Cape. And the logic to not have it notified is increasingly challenged as the numbers really rise globally and locally. So I've just put in a table here as to why it should be and why it shouldn't, why it probably isn't. It has a long incubation period, so it's not really doesn't really follow typical outbreak dynamics. Treatment occurs in tertiary centers and perceived as ready. And that also competes, of course, this is the main reason, high profile public health priorities. So the argument for South Africa to have it notifiable is that it's endemic, there's rural foci, there's widespread home slaughter, poor dog deworming coverage, One Health coverage, and the tourism and livestock movement to consider. There's a large untreated cysts that really present very late. That it might be extremely beneficial for South Africa to improve detection, guide resource allocation, and contribute to a One Health collaboration. So just in conclusion, and the take-home message is that hydatid cysts in pregnancy require multidisciplinary team. Transitional stable cysts are often stable and observation is preferred. And observations with expected management, close follow-up is preferred for asymptomatic small calcified cysts that are located in the posterior segments. Albendazole is best to avoid it in the first trimester. One should be cautious in the second, third trimester. And surgical intervention is reserved for complications. Normal vaginal delivery is safe in most cases, and neonatal screening isn't routinely done. Those are my references.